Hello friends, so today we will be seeing Neet PG 2025 medicine recall. So first one, a 70-year-old hypertensive patient in atrial fibrillation with complaints of weakness of upper and lower limbs on one side since last 2 hours. His NCCT brain was done, which was found to be normal. Next step in the management. So basically the management of stroke with a cardioembolic history they have given. So how to approach it? First is always in stroke, there should be NCCT head which should be done within 20 minutes of arrival of the patient just to rule out hemorrhage. If you see white areas with hemorrhage with surrounding edema, that suggests intercerebral bleed. Or if you have just infarct, or it might be a normal CT also, that might indicate ischemic stroke. So management options, first is always to stabilize the ABC, airway, breathing, circulation. Next, BP and dextrose control. In this question, BP was not mentioned, I suppose. And next thing should be to go for NCCT head. So NCCT head was done. So here we are found to be a normal, to be normal, and patient is found to be within the window period. It was given only 2 hours. So now the time since symptom onset is just 2 hours for this patient. So if RBC is given, then if random blood sugar more than 180, we must be treating it. Less than 60, there also we must be treating it. Within 140 to 180 is the ideal range of red blood sugar. And BP control in ischemic stroke, if the patient is going for thrombolysis, BP should be controlled to less than 185, 110. Okay, yes. So next is time since onset. First is if it is less than 4.5 hours, regardless of the etiology, if there is no contraindications for thrombolysis, first option should always be thrombolysis. Okay, so if the patient is thrombolysis eligible, then you should go for IV RTPA, which is alteplase. Okay, if he is not eligible, we can go for a CT angiography to look whether the patient is a suitable candidate for mechanical thrombectomy or not. But if the patient is presented between 4.5 to 24 hours, then the only option is mechanical thrombectomy. And if the patient is eligible, we can same management option for the patient. If it is 24 hours, no treatment option, only to give antithrombotic as well as statins. And see, there is the indications for thrombolysis, age more than 18 years, time since onset less than 4.5 hours, and BP less than 185, 110, and clinical diagnosis of an ischemic stroke. Everything was fulfilled in that question. And you should always see whether there are contraindications to thrombolysis where there are not. Contraindications are any hemorrhage like prior hemorrhagic stroke, subarachnoid hemorrhage, or any head injury ischemic stroke in the last 3 months, or GA bleed which can be active or which can be in the last 21 days, or any malignancy. And contraindications with respect to cardiovascular system is active infective endocarditis, aortic dissection. The fear of progression of dissecting the lumen is there. So we contraindicate thrombolysis there. So in atrial fibrillation, there is no contraindication to go for thrombolysis at all. So the best option should be to go for thrombolysis. Next was a diabetic patient who was on insulin and tapped metformin. Still HbA1c is 8.3 with signs of heart failure. Next appropriate add-on medication is. So here, if you see with respect to ADA 2024 guidelines, the appropriate thing to add after metformin is always should be a SGLT2 inhibitor or a GLP-1 agonist. So here also the patient is having heart failure features also. With respect to your latest ACC guidelines with respect to heart failure, if you see, everywhere in stage A, B, C and D, all stages of heart failure, you will be seeing this drug here, which is nothing but the SGLT2 inhibitors. In all phase, you can see this SGLT2 inhibitors having class 1 indications to give to start on this therapy. So obviously, you should be going for SGLT2 inhibitor, which is nothing but empagliflozin in this option. Next was a 60-year-old male with a history of ischemic cardiomyopathy showing narrow complex tachyarrhythmia. He is hemodynamically stable. Decision is made to initiate antiarrhythmic therapy and IV amiodarone is started. You are shown the following schematic of the ventricular action potential with 4 phases they have given. and they have asked what is the phase which is going to be affected by amiodarone. Nothing but mechanism of action of amiodarone they have asked, and what phase does it affect. So this is the cardiac action potential, phase 0 favored by rapid depolarization, where the sodium channels are trickled in, causing the QRS complex in the ECG. And there is next phase is the phase 1, which is the rapid repolarization, where the potassium are effluxed out of the cell. And in the phase 2, as much as potassium exit out of the cells, same amount of calcium influx happens, so that this is getting neutralized, and this is the ST segment in the ECG, followed by only K plus efflux out of the cells, contributing to the phase 3 of action potential. This contributes to your T wave in the ECG. So if you closely see the antiarrhythmic amiodarone, it is a potassium channel blocker, though it has lot of mechanisms apart from blocking potassium channels. It is the main mechanism is potassium channel blocker, which prolongs the action potential, and it also prolongs the T waves, so that indirectly it increases the QT interval. So if QT interval is increased, there is a proarrhythmic risk with amiodarone also. But if you see, QRS will be normal with amiodarone, and only QT prolongation will be seen. Okay, it affects the phase 3. So answer should be phase 3 repolarization should be affected by amiodarone. Next is PDA, patent ductus arteriosus, develops from which of the following arch? It's nothing but, if you see the arches of development, if you see here the 6th arch, see here the 6th arch usually develops into left and right side. Right side will give to right pulmonary artery, whereas the left side will give to left pulmonary artery, and the distal part of the left side will give to this ductus arteriosus, which connects with the aortic arch, which develops from the your 4th arch. Okay, so the ductus arteriosus develops from the left 6th arch distal part. Okay, so this is the left 6th distal part of your arch. Next, drug used for prophylaxis of PSVT. So prophylaxis, they have asked if PSVT happens, acute management should be vagal maneuvers like carotid sinus massage or carotid sinus stimulation by stimulating your vagus nerves by facial stimulation or spraying ice cold water on face, coughing, gagging, massaging. Okay, all these things. And then comes the carotid sinus massage, and then comes your ABC group of drugs like adenosine, beta blockers, calcium channel blockers, which will be giving IV. Prophylaxis, if they have asked, their option should be any oral calcium channel blocker or oral beta blocker. Okay, so here oral verapamil was given, so that should be the correct answer. Next is ABG of a patient they have given. I don't know the exact values, like pH was low and PCO2 was very high, and mostly the answer is respiratory acidosis. This was the values almost. So basically in ABG, they have just started with the second step itself. We got the answer. First, you always look for the pH. If the pH is less than 7.35, it is acidosis. Then you go see for the PCO2. If it is more than 40, which is the normal value, if it is more than 40, then it is respiratory acidosis. So in our exam, it came out to be acidosis, and PCO2 was high, so it was a respiratory acidosis. Next, one more question was asked, and where the values I don't know, but they have asked for the anion gap calculation and what metabolic acidosis was the ABG answer for that. So anion gap, what is anion gap? It is nothing but, see this picture, it is nothing but the unmeasurable cations, which are the K plus magnesium and calcium, and unmeasurable anions. Here sulfate, phosphates and proteins. Okay, if you subtract this gap, okay, this is the anion gap, which is the difference between the unmeasurable anions with the unmeasurable cations. Okay, so obviously how to get this anion gap is nothing but just take this part, which is the sodium part, and subtract the calcium and bicarb from this sodium part. You will get this anion gap. So sodium minus chloride plus bicarb is the formula. So this came out to be 30, and hope that was a ABG suggesting metabolic acidosis where the pH was low and bicarb was less than 24. Okay, so causes of hugma in a nutshell we can remember by a mnemonic called CAT mud piles. C for carbon monoxide and cyanide poisoning, A for aminoglycoside poisoning, T for toluene, M for methanol, U uremia, D for diabetic ketoacidosis like alcohol or starvation, and P for any pills like iron, isoniazid, and L for lactic acidosis, E ethanol ethylene glycol, S for salicylates. If you see all the causes of hugma, it will come under three causes. Either it can be a toxin abuse, or it can be a drug abuse, or it can be heart failure or ketoacidosis or CKD. So 5 basic zones will be the causes for your hugma. Next is periauricular hemorrhage was given, and patient was having some bleeding history also. Symptoms got normalized after giving vitamin K injection. So options were hemophilia, biliary duct obstruction. It's nothing but a fat soluble vitamin deficiency. Because of biliary duct obstruction, your fat soluble vitamins are not able to be absorbed properly, leading to this vitamin K deficiency, acquired vitamin K deficiency, and it got corrected by vitamin K injection. And ninth question, a patient with the right-sided weakness of one side, which was element type I think suggested, with absent reflexes on that side, with no sensory deficit. Site of localization they have asked. So here if you see, first we should be able to know to differentiate LMN versus UMN. So here it is nothing but properly the tone is flaccid muscle weakness with loss of power and loss of reflexes are there, such as true of a LMN type of lesion. Okay, and in LMN lesions if you see, it can be from the anterior gray horn or from the root or from the nerve or from NMJ or muscle. Okay, so here specifically they have given there is no sensory deficit. If no sensory deficit is there, then nerve is not a possibility. Okay, and also in options if you see, in among the element group they have given anterior gray horn. Okay, right anterior gray horn they have given. This is a potential answer for this question, because if it is internal capsule, it will be a human type of weakness with exaggerated reflexes. This is not the case here. If it is nerve, it should have involved sensory component also. Sensory component was not there. So mostly it is right anterior horn cell. Next is carpopidal spasm complication of which surgery? It is nothing but complication of thyroid surgery, where due to removal of your parathyroid gland, your PTH won't be secreted, and this will cause hypocalcemia. Okay, usually what calcium does is calcium usually plugs the sodium channels which are in the nerve neurons. Okay, so in hypocalcemia there is no plugs to these sodium channels and sodium start intruding well. Okay, this will cause unnecessary depolarization and continuous muscle contraction, which is nothing but which will result as tetany or carpopidal muscle spasm. All these things can be seen, and this is the basics also for laryngospasm, bronchospasm, Trozius sign, tetany. Everything happens because of hypocalcemia resulting in this spasm. And next thing, hyponetriia patient develops signs of stroke. Next investigation of choice to do is, see, hyponetriia patient with correction with 3% NS, these patients are more prone to develop a syndrome called osmotic demyelination. So if there is demyelination and edema over the brainstem region, this can't be visualized easily by your CT scan. It is better to do MRI to precisely localize the area affected and diagnose ODS. And also ODS closely resemble brainstem stroke in multiple aspects, like the patients might have spastic quadriparesis, patient might have pseudobulbar palsy, okay, dysarthria, dysphagia, emotional lability, okay, because the bulbar nerves, which are the lower 9, 10, 11 nerves, the human control for these nerves will be lost. And patient might go also into a syndrome called locked-in syndrome, where due to involvement of all the 4 limbs with altered consciousness. This is also possible with oculomotor dysfunction. So all these might mimic stroke. So if you want to exactly differentiate stroke from ODS, obviously the best option is to go for a MRI. Next is, which of the following conditions is likely to follow this pattern of inheritance? So if you see here, A. Duchenne muscular dystrophy, B. Huntington's, C. Kearns-Sayre syndrome, D. Marfan syndrome. So here if you see, the mother is affected. When the mother is affected, all children are getting affected. Okay. And here if the male is affected, no one is affected here. If female is affected, all are affected here, which means this disease is traveling from the mitochondrion. Mitochondrion is one thing which transmitted through the ova. So this is nothing but they are asking for a disorder which involves mitochondrial inheritance. Amongst this, Kearns-Sayre syndrome is the one which follows mitochondrial inheritance. Yes, thank you. Keep following our channel for more updates on the recall. Thanks.